Good afternoon, everyone. I'm Nora Volkov. I direct the National Institute on Drug Abuse, and it's an honor for me to present today Dr. Sharon Walsh, who has been one of our star grantees for many, many years. And now, amidst the opioid crisis, where the NIH is coming together to come up with solutions, I can think of no one that has, by her work, contributed so much, but on the other one, prepared to continue to contribute as we embark in such an aggressive enterprise to get new treatments. And I would say that Dr. Sharon Walsh probably has been instrumental in generating a lot of the evidence that we currently have about the effectiveness of medications for the treatment of opioid use disorders. But her work is much more extensive than it, and you are going to be hearing some of it. And she comes actually from an extraordinary tradition. She's at the University of Kentucky, which is where NIDA originated, where actually the concept of doing research in order to come up with treatments for addiction emerged. It was in the University of Kentucky. And since then, we have had a tradition of extraordinary researchers that have come out of this university and for which we have all benefited. So she's currently a professor of behavioral science, psychiatry, pharmacology, and pharmaceutical sciences at the College of Medicine and Pharmacy at the University of Kentucky. And she's also the director of the Center on Drug and Alcohol Research at the same university. She received her BS in psychology from Shippensburg University in Pennsylvania, her master's in behavioral neuroscience from Rutgers, and her PhD in behavioral neuroscience from Rutgers University too. Her postdoctoral training was done at the Johns Hopkins University School of Medicine, and after which she joined the faculty for 13 years, and from there went to the University of Kentucky, where she's currently a professor. Her research has been focused on pharmacological and behavioral issues in opioid abuse and physical dependence, including studies on the pharmacodynamics and pharmacokinetic characteristics of opioid-dependent pharmacotherapies, such as buprenorphine, methadone, and levometadiol acetate, or LAMP, for the treatment of opioid use disorders. And more recently, she has also started to investigate the addiction and the treatment of opioid prescription analgesics, such as oxycodone, hydrocodone, tramadol, and morphine. She has been funded by NIH continuously throughout her 25 years career. On her talk today, she will be discussing leveraging science to change hearts and minds, addressing the opioid crisis. Please join me in welcoming Dr. Sharon Walsh.
Thank you. Thank you, Nora, and welcome, everybody. Thank you for attending this afternoon. It's a real pleasure to have the opportunity to speak with this group. As Nora said, I'm going to be talking about how to leverage science in order to change hearts and minds, and this is really about the gap between what we know to be true based on the evidence versus what gets implemented in the community. So these are my disclosures. Over the last year, I received consulting fees from Pfizer, Eli Lilly, Brainsway, and Trevi. And this is the outline for my talk. So I'm going to start by providing a little bit of epidemiological update on where the current crisis is. And then I'm going to describe a potential framework for addressing the opioid crisis. I want to discuss some specific interventions and the scientific evidence that supports those. And then in this context, I want to talk about what we're doing right and what we're doing wrong and maybe what we should be doing differently. And finally, end with some recommendations for change that are my personal opinion. These are the most recent data that are available from the CDC, showing the increase in opioid overdose deaths by year, with the numbers for 2017 coming in at roughly 50,000 individuals. I think that we are seeing a downturn in prescribing. It's not really dramatic, but we are seeing decreases in prescriptions for opioids. So some of our practice interventions are making a difference. But I think that if it hadn't been for the fentanyl analogs entering the illicit marketplace, we probably would have seen either a stabilization of deaths or even maybe a slight downturn, but that's not what happened. And in part, that's attributable to the fact that we now have illicit fentanyl and illicit fentanyl analogs in the supply, really that's spreading across the country. So just as an example, I'm in Kentucky, where 10 years ago, heroin wasn't even available. And if someone was an opioid user, they were using prescription opioids. And then heroin entered the market. And last year, we had about 1,500 deaths from opioid overdose, and 700 of those involved illicit fentanyl analogs. So they're really widespread, and it's very deadly because, of course, fentanyl is so much more potent than the other opioids. And oftentimes, people don't even know that this is in their supply. So there are stories where people think that they're buying cocaine, and they actually have gotten fentanyl. They're buying pills that they think are oxycodone, but they're actually just pressed to look that way, but they're actually illicit fentanyl. All right, so this is a really complex problem. It's a problem that is a medical problem, it's a behavioral health problem, it's a criminal justice problem, it's a legislative problem and policy. And there are a number of different primary approaches that have been catalyzed in order to address the crisis in the United States. And these include law enforcement, interdiction in jail and prison. We tend to spend more on this, actually, than the other categories of interventions. Prevention, like primary prevention, such as provider education and reducing prescribing, the use of prescription drug monitoring programs, and other types of interventions. Treatment for those who actually are already suffering from opioid use disorder and are at highest risk of overdose, including earlier intervention and expansion of treatment. And finally, addressing the associated harms that come along with opioid use disorder, including treatment of infectious disease, naloxone distribution, and syringe service programs. So I'm not going to talk about law enforcement because that's not the area that I work in, but I am going to talk about each of these other categories and try to give you a little flavor for some of what's happening in those categories and where we're making an impact. So first, with respect to prevention, there's been a lot of discussion about changing guidelines. The CDC, World Health, other organizations have changed prescribing guidelines around opioids, and we're trying to impact physician behavior, which I think is sometimes easier said than done. We're also trying to do a better job of intervening earlier so that we actually provide some training around good prescribing practices for health professionals, because historically, there's been very little focus, for example, in medical school curriculum around good prescribing practices and how to identify substance use disorders. So just as a reminder, the current crisis in the United States actually began with expanded prescribing for chronic non-cancer pain and was really propelled by what I would say now are unconscionable and greedy pharmaceutical manufacturers, distributors, and sometimes, but less so, even providers. So I don't have to tell you about that because it's been in the newspaper. There have been lots of lawsuits. There's been terrible publicity for companies. And there have been some large payouts to states, both from pharmaceutical manufacturers and from distributors, to try and make right what was done that was wrong. But I would note that there really has not been any case of incarceration of pharmaceutical executives, but there have been many doctors that have been locked up for bad practices. And so there's something that's a bit askew here, and maybe if we really want to stop the bad behavior that's propelling this at the level of the industry, we need to change the way that our consequences are designed, because this is still a battle. Despite everything that we know about what Purdue did in the early 90s and the consequences that were paid, Purdue, a few years back, reinvented itself abroad as a new company called Mundy Pharma, using the same marketing to South America and Europe and Asia. And this is a quote from their head of Mundy Pharma Emerging Markets, Singh, said publicly that pain treatment in Asia is 1/50th of what it should be. So this is an advertisement that is actually targeting China, which would be a really big marketplace, but would also be a huge public health catastrophe if what happened here happened elsewhere and in South America and the other places that are being targeted. Most recently, Purdue has developed a new patented wafer for buprenorphine, which is a treatment for opioid use disorder. And a well-known journalist, Lily Danziger, said that the idea of Purdue and the Sacklers swooping in with the cure for an epidemic that they've actually profited from with a new product that will make them even richer, however, feels like the darkest form of capitalist absurdity. In fact, Purdue is still undergoing litigation for some of their past deeds, and they've now made an offer to the government that rather than paying the fines for this, they'd like to actually provide their new product of buprenorphine to treat people in lieu of money. I mean, you just can't make this up, actually. This is, it's very peculiar. So these are data that were published by Ted Cicero showing the change in the risk for someone to develop opioid use disorder. So these are treatment admissions, people who are coming into treatment for an opioid use disorder. And you can see that in the 1960s and 70s, long before the prescription epidemic started, that virtually everyone who was presenting because they were using heroin. And that crossed over in the 1990s after the excessive marketing of OxyContin and other opioids followed, so that now it's much more common for people to present having used heroin or having used prescription opioids first. And it's estimated, I should back up, it's estimated still that maybe about 80% of the people who are presenting are still reporting prescription opioids first. So that's something that we still have a long way to go. These are other data that show, this was from a commercial database of insured patients who had a non-fatal opioid overdose during long-term opioid therapy. And what was discovered in evaluation of these data was that 63% of the high-dose opioid patients who had had an overdose were still on a high dose anywhere between 1 and 3 months after that overdose. And that 17% of the high-dose patients had overdosed again within 2 years. Additionally, a good percentage of those people also had active prescriptions for benzodiazepines, and we've long known that the combination of a benzodiazepine and opioids is a perfect recipe for fatality because there's some synergistic effect on respiratory depression when those are both co-prescribed. So co-prescribing of benzos with opioids really should be an exception rather than the norm, as it is here, that is 30%. These are data from a recent study that was just published last year, where this very simple intervention was done by an investigator whose last name is Doctor. I like that, as Doctor. Where what they did was they looked at overdose deaths, and they took about half the cohort of individuals who had died from an overdose in which the thing that they overdosed from was also something that they had been prescribed. And with half of those people, the doctor was notified with a simple letter letting them know that their patient had died and had on board the thing that they were prescribing, and the other group didn't get a letter. And so you can see that in the group that got the letter, just notifying them of a potential role for their prescribed medications in the death, that there was about a 10% decrease in actual prescribing behavior. So this was actually about a change in behavior rather than a change in knowledge, which is important. So what's plotted on the y-axis there is the mean morphine equivalence in their overall prescribing practice. So the peculiarity about all of this is that it came about because we expanded prescribing for all kinds of conditions with opioids that historically had not been treated with opioids. And so the idea that anybody that has lower back pain or has arthritis in their knees, which basically accounts for probably 75% of the people that are over the age of 50, might do well if they receive opioids for that condition. There really wasn't any evidence for that, but it really took hold in the medical community. And the existing studies, although they were largely observational, suggested that chronic opioid use in pain patients is actually associated with poorer pain outcomes, increased functional impairments, and poor return to work numbers. So at least the observational data didn't really show a great benefit, but those aren't necessarily controlled studies. So there was a meeting that was put together by NIH, Nora was involved with this, the Pathways to Prevention report, where they brought together a lot of experts to talk about what was known. And basically what that report concluded was that there was no strong evidence or prospective evidence to support the efficacy of long-term opioids. And I love this quote. Particularly striking to the panel was the realization that evidence is insufficient for every clinical decision that a provider needs to make about the use of opioids for chronic pain. And so one of the things that came out of that meeting was the call for the need for stronger evidence, because there was some evidence available, but when you rate it according to how strong the evidence is, it was relatively weak. And so there was a call for more prospective studies. And finally, some of these are starting to roll out. So this study was just published late last year, and it was a pragmatic trial that was conducted in 62 Veterans Administration primary care clinics, so it's a fairly large study. And in this study, they enrolled patients with chronic moderate to severe back pain or hip or knee osteoarthritis, and they were randomized either to receive opioids or a non-opioid regimen. And dosing was titrated to achieve target pain scores and progress towards individual goals, with 3 possible steps of escalating prescribing. And so the 2 different regimens are shown here. So for the opioid group, they would start with kind of the low intervention opioid, which would be an immediate release of morphine or oxycodone. And if they weren't having satisfactory response, then they would move to a sustained release formulation. And if that didn't work, they could work their way up to fentanyl. In the non-opioid group, they would start with nonsteroidals, and then they could move to topicals, gabapentin, or uptake inhibitors. And then the third step for them would be to go to tramadol, which is an atypical opioid, and pregabalin. And these are the results. After a year of study, looking at the brief pain inventory for interference shown on the left and for severity of pain shown on the right, you can see that there's absolutely no difference between the groups, regardless of whether they are on an opioid or a non-opioid regimen. And moreover, as you can imagine, the opioid group actually had more adverse events that were related to medication than the non-opioid group. So when you look at data like this, and you think about going to the FDA to get approval for a new indication, there's absolutely no evidence of efficacy that opioids actually are useful in this set of conditions according to this trial. More trials are coming out, and we'll see what the results are, but I wouldn't be surprised if we see very similar results. So with respect to for prescribing for pain, we've come out with a lot of guidelines and recommendations, but some of the things that I've been thinking about is, like, how about if we go back to prescribing opioids for only the things that the evidence supports? You know, can we retreat from this? Can we use it for acute pain, like time-limited prescribing? You know, someone has surgery. You want to have opioids after surgery. We don't want to withhold that. And chronic cancer-related pain and other palliative care. Maybe we should consider removing the generic package insert language that's not specific to condition, because as it reads right now for most of the opioids, for the management of moderate to severe pain, without respect to what the condition is or what the duration of treatment should be. I think that we need to hold the companies responsible for their actions, particularly in light of the fact that it is continuing to go on. And of course, we need to continue to conduct controlled studies to evaluate other conditions and patient populations. But I would really love to see this whole prescribing become an opt-in rather than an opt-out, which is the way that it's framed right now. So the next topic is, as a primary approach, is to increase treatment for opiate use disorder and have earlier intervention and expansion of MAT, which is the language that's used around treatment for opioid use disorder with medications. It stands for medication-assisted therapy. I think throughout the rest of the talk I won't refer to it that way because I think that in and of itself is stigmatizing. So there was a paper published late last year by Keith Humphreys and his colleagues in which they used dynamic modeling to account for the broad array of interventions that we're trying to deploy, including reducing prescribing rates and increasing opioid disposal programs, increasing treatment. And what they estimated was that without further intervention, if we don't do anything different than what we're doing right now, that in the next 5 years we'll have another 250,000 deaths, and in the next 10 years we'll have another 500,000 deaths. They also were able to parse out what the relative importance of each of the types of interventions were and what kind of impact they could have. And what they concluded was the most impactful interventions would be expansion of treatment for opiate use disorder and interventions to mitigate the harmful effects of opioid use disorder, including overdose and infectious disease. This is a paper that was published by Williams this past year in which they took the cascade of care from the HIV field and applied it to opioid use disorder. And what's shown here in the far left bar is the total number of the population. It's not to scale, the actual values are embedded within the bar. And then as you move across, how many people are actually at risk of using opioids, and here it's estimated to be about 12 million. How many have a diagnosable opioid use disorder? Here it's estimated to be about 2.5 million. We actually think that those numbers are probably underestimates because it's really hard to get good data at a population level around something that is somewhat hidden and stigmatized and not always screened for. As you go down the cascade of care, though, moving from who gets diagnosed to who gets engaged in care to who actually starts on medication, all the way down to who can sustain remission, you can see that the blue numbers are getting lower and lower, and that means that our penetration of what's needed to fill these gaps is less and less with each step of the cascade of care, and the red represents the gap. So we need to do a much better job in being able to reach people and deliver effective treatment. So what is effective treatment? I think that this is probably one of the things that's most controversial, where we have the greatest gap between what the public thinks and what the experts think. And so, you know, everybody thinks that they know something about substance abuse because everybody knows somebody that has used substances, you know. So if you tell people what you do for a living and, you know, you're at a party and you say, you know, you develop medications for substance abuse, people will have very strong opinions about how you really should go about doing this and what is effective treatment and what people really need, which wouldn't happen in any other area of medicine, I think. So it's kind of a peculiar thing. One of the most common forms of treatment that we use is incarceration, which is actually not treatment at all, although it does stop people from using drugs as long as there aren't drugs in the jails and prison, but that's also not usually the case. We talk a lot about long-term residential programs, which are quite costly and really a big investment. And for families who have a loved one who's impacted by substance use disorder and often opioid use disorder, you'll learn that they have spent their fortune, they've remortgaged their home to have multiple stints at a recovery center with no positive outcome. Peer recovery programs are growing in support, so it's if somebody actually had a drug use disorder themselves, that somehow now they're an expert on it, and they're going to do a very good job at delivering treatment. And then we have medications, and we're fortunate with opioid use disorder that we have 3 medications that are approved by the FDA, which means that they've been demonstrated to be effective, including naltrexone, buprenorphine, and methadone. But then there's a lot of talk about other medications that may be useful. So kratom is one that's getting a lot of publicity, Ibogaine for a while, and now there's this whole discussion around marijuana that, you know, if you legalize marijuana, that your overdose rates for opioids will go down, and people, if they use medical marijuana, they'll use less opioids. I'm just going to say that at this point, the data are not in to support those things. So these are things that catch a lot of attention, and particularly from the marijuana industry, it's a good selling point, but we don't actually have strong data yet. So all of these things are available, but detoxification is probably the most common deployed treatment in the United States. And so what do we know about detoxification? This is a treatment program that is not too far from where I live. I won't tell you where it is, but I don't think it's all that unusual. So now, if you had a loved one that you wanted to go send into treatment, I'm not sure that you would want to send them to a place that looked exactly like this. But you can see that the beds are numbered. So, and this is the whole space that an individual would have. Now, by descriptive reports of this facility, here are the clean sheets, and at the other end of the room are the sheets that are filled with vomit and diarrhea from people going through withdrawal. So this was something that was published about this local treatment program. The heroin epidemic plaguing the XXX community has led to unprecedented demand for services. About 90% 95% of men and women in detox are addicted to heroin, but nearly all clients have been abusing multiple drugs. So they got $29 million in new funds to expand their detox beds. And patients spend anywhere between 1 and 9 days detoxifying themselves with nothing other than mild pain relievers. And also quoted as the facility believes in full abstinence. So there's several things that are wrong with this. I would say, first of all, facilities actually can't have belief systems. I think only people can have belief systems. The fact that they could get $29 million to expand beds for something that's not evidence-based is problematic, and where did those funds come from? And the fact that we actually have effective treatments, both for tapering people and for sustained treatment that could be used, and that those are excluded and precluded from this treatment setting. So what do we know about detoxification? This is a study that was done by Bob Newman, who was really a giant in the methadone field, and he sadly passed last year. This study was done in 1979, so this is not a new lesson. In this study, trying to promote the effectiveness and utility of methadone, he randomized 100 individuals who had been stabilized to methadone on 60 milligrams. And one half of that group remained on methadone for 32 weeks, and the other half was tapered by 1 milligram per day over that same time frame. And at the end of the treatment period, 76 remained in treatment who were on active methadone, and only 10% were remaining in treatment who had been tapered. At 3 years later, this is a long study, 56% of those patients who were on methadone remained in treatment, while only one person was in treatment still in the detoxification group. So that was completed when I was in high school, and I'll just confess that was quite a while ago. But we actually have other data that show the same thing. So our colleagues Marcus Heilig and Johan Kakko conducted a similar study, kind of against their own personal wishes, but because they were living in the context in Sweden where the Swedish government was really being very draconian about regulations for people to get into methadone. So they were really trying to keep people out of methadone treatment. And so what they did was they designed a study to show that medication versus detoxification, to compare their relative efficacy. And in this case, they used buprenorphine, which was newly available there. And this study, they enrolled people to detoxify with a lot of psychosocial supports or to remain on treatment for a period of 1 year. Not only did everybody drop out in the detoxification arm, but 4 people, or 20% of the whole cohort, had died within the period of the study, and those people died of opioid overdoses. So not only does detoxification not work to keep people in treatment or in remission, it also is actually a risk for overdose death. So then why is this the most common treatment that we're still deploying in this country? So there's lots of residential care, and a lot of residential and recovery housing offers only detoxification and peer support. Peer support is a big movement that's underway right now, but I would just say that we don't really have much evidence to support its efficacy. Some of these have few or no licensed health or mental health providers and are not actually treatment facilities, although they may have a name that makes it sound like it's a treatment facility. And these funding streams often come from criminal justice or housing authorities, so they kind of bypass the regulations around treatment programs. So the solution, I believe, is really to increase the effective delivery of medications in all settings. What we know about pharmacotherapies, and this applies to all 3 that are FDA approved, is that they save lives, that they reduce illicit drug use, that they reduce disease transmission, they reduce drug-associated crime, they improve psychosocial function. And so you might think that when you have something that has that whole package, that it would be deployed really easily and that there would be great uptake of this. But it's actually a lot easier said than done because there are a lot of barriers, and these include cost. We have an inadequate workforce, which we're working on. There are a lot of insurance barriers, but probably the biggest barriers are stigma and outright discrimination. There are lots of settings where we should be thinking about expanding care, including jails and prisons, parole and probation. This is a great place to meet people where they are that are at very high risk for having substance use disorders and may be receiving no treatment in those settings. recovery programs that are abstinence-based only, hospital settings, emergency departments. There's a whole movement around trying to get into hospitals and start care in emergency rooms that's been very fruitful. Various community settings and ordinary medical practices so that we're trying to expand care rather than have it be so siloed as it has been historically. And I would argue that we should expand into every treatment program that currently doesn't offer it or believe in it. So how are we doing with this? Well, we've made some modest increases, and this slide is from Morgan and Shackman and Alex Wally and their group. And what this shows is using a commercial database looking at the total number of months for which reimbursement was provided for one of the FDA medications from the period of 2010 to 2014, you can see that the actual delivery and exposure to medications has increased. But at the same time, in the green, the absolute numbers of people who are affected by opioid use disorder are increasing. So on a percentage basis, we're actually losing some ground. Another thing that we really need to focus on is we have very poor continuity of care. And so we're doing something wrong. And some of it may have to do with the structural barriers that we have around this treatment. But from this same study by Morgan's group, they also looked at discontinuation of medication using this commercial claims. And what they found was that for those who were starting on injectable naltrexone, so there's a 30-day depot formulation, that about 52% of them actually didn't come back for their second injection. So that's people are getting treatment for 1 month, and then half of them are gone after that. We have better adherence or retention with sublingual buprenorphine naloxone at 31%, but still, it's really quite low. You know, we really should be doing a better job. This is a chronic disorder that people need to remain in treatment, and so we need to figure out really what are those services that are necessary. And this is really very similar, I think, to the HIV situation, where the initial treatments were challenging, getting to the population was challenging, and with the Ryan White program, they really came around with a whole idea of how to wrap the patient up with wraparound services and provide them with the support that they needed, transportation and other things, to improve adherence and to improve treatment outcomes. We're not quite there yet in the field of substance use, but I think that that's the direction that we need to go. So we do have new tools that are available to us just in recent time that we're excited about. We have a couple of different products that are sustained release formulations of buprenorphine. And I think in general, you might think that a sustained release formulation is beneficial to the provider and to the patient for the sake of convenience. But in this case, it's much more important than that. And the reason for that is that there's a lot of stigma against buprenorphine as a treatment itself, and that's because it has psychoactive effects and it can be diverted. So in places that have very limited access to treatment, when buprenorphine providers become available, a lot of times people who need treatment can't get it, and people who are trying to suppress their own withdrawal can buy buprenorphine more cheaply than they can their drug of choice, like heroin or oxycodone. So the stigma associated with the diversion of buprenorphine has actually led towns to pass zoning laws to prevent new providers from coming into town and be able to practice. So it's an interesting dynamic, because if you talk to people in some of these communities, they actually think that buprenorphine is the problem, as though there wasn't an opioid problem before buprenorphine appeared. And so they blame it on the treatment agent rather than recognizing that they actually have a fundamental problem with opioid use disorder. There have been a number of studies that have been done around this topic, interviewing or surveying people who have misused buprenorphine, meaning that it wasn't theirs, both in the US and in other countries as well. And the two reasons that always rise to the top of why somebody says that they did divert or misuse buprenorphine is because they can't access treatment and because they're trying to treat their own withdrawal symptomology. So for the sustained release formulations of buprenorphine, the added benefit potentially is that it will decrease the risk of misuse and diversion. It will make it easier for practice. It'll decrease stigma for patients. A lot of patients don't even like to go into the pharmacy to get their prescriptions filled because the pharmacist knows what they're using it for and they feel stigmatized there. But the idea that you could actually, as a provider, give somebody a depot injection, know that it's going to remain in place, no one else is going to have it, and it's not extractable, would go a long way to probably reducing some of the stigma. So this is the first product that was approved just 2 years ago, and this is an implant product that is similar to the way that implantable birth control works. So 4 rods produce sustained release of buprenorphine for up to 6 months, and it's very effective, but it's intended for patients who are already stabilized only on a low dose of buprenorphine at 8 milligrams or lower, and I'll show you kind of a continuum of care in a minute. But 8 milligrams is on the low end of the spectrum. So this would be a product that would be useful, but only for a portion of the patients. These are the primary outcome data from that pivotal study. And I think that these are really important for a couple of reasons. The first thing to point out is that 166 of 177 people who were randomized completed this 6-month study. So here we have 94% retention. And in that earlier slide by Shackman and colleagues, you saw a much lower rate of retention. The difference here is that these are stabilized patients. So they had to be stabilized on buprenorphine before they came in. So what this tells us is that when patients are doing well in treatment, they want to be in treatment and they're willing to stay in treatment. If you look at the primary analysis outcome for having 4 of 6 months without any illicit opioid use, you can see that the numbers for the implant are 96% and 87% for sublingual buprenorphine. And for a total 6 months of complete abstinence, you can see that the numbers are still quite high. So I think that these are important because a lot of times when we do clinical trials in substance users, we have low retention rates. We have very high dropout, and that is problematic for several reasons because it really impacts your power. When you have dropout, we tend to assume that someone drops out is because they've actually relapsed to drug use. So oftentimes there's a rule that you have to count any missing urine test as being positive. But this shows us that people who are in treatment and who are motivated for treatment can really do well with very little intervention over at least a 6-month period of time. These are the results for the second product that just recently came onto the market last year. And this is a monthly injectable sustained release formulation that's a subcutaneous preparation. And shown in the left panel is the cumulative distribution function of percent urine samples negative for opioids and combined with negative self-reports, because that's what the FDA requires, is that both your urine has to be negative, and you also have to say that you hadn't used. And what they did was they looked at 2 different dose regimens. They produced equivalent effects. In the blue line, you're looking at a placebo control. This company chose to do I need to point it here, chose to do basically the detox function that you saw on the other slides that I showed earlier, and so they looked similar. The third product is called CAM 2038. And this is also a subcutaneous injectable formulation that comes both in weekly and monthly doses, and it's available across a range of doses. So their pivotal outcome was looking at mean percent urine samples that were negative for illicit opioids, and the response rate is defined by the FDA. And I'm showing this because in this study, what they did was a non-inferiority design. They compared it to the active sublingual preparation that's already currently available and has the majority of the marketplace. And so anything that is to the right of the dotted line, this is where it's neutral for non-inferiority. Anything to the right was favoring the sustained release formulation. Anything to the left would have favored the sublingual formulation. And what they found was that it was non-inferior, so it met the criteria for both safety and efficacy to be approved by the FDA. So this is the continuum of care around buprenorphine treatment. So shown here is from 1 milligram of maintenance up to about 32 milligrams per day. 24 milligrams sublingual is the maximum that's recommended in the FDA package insert. And in the United States, our average is somewhere around 16 point some milligrams. The probufene implants cover this range, 8 milligrams and below. And the subblockade low dose injectable covers from about 24 milligrams on. And the higher dose regimen produces even higher concentrations and is recommended for reserved cases. The CAM2038 product comes in both the weekly and monthly and actually covers the full range of the spectrum. So unfortunately, though, that's not available. And it's not available not because it didn't meet the criteria, but it's not available because the FDA made a decision that they wanted to grant exclusivity to this other product. And by doing that, they said then this CAM2038 couldn't come onto the marketplace for another 3 years. So for full disclosure, I was involved in the studies with CAM2038, so you might think that I have a bias because of that. But I think more importantly, in the context of this crisis, we have limited options. Here we have a few new products coming on the market. Nora and other people at NIDA have long worked hard to get the pharmaceutical industry interested in this area. They've thought that it's not profitable enough or that it's stigmatized. They don't want their name associated with it. And we're finally making some headway. But the lesson here is, you can do all of that work and spend all that money, but then perhaps you still aren't going to be able to get your drug to market. So the FDA commissioner, Scott Gottlieb, who just stepped down yesterday, I think to many people's chagrin, said, we've set out to address the opioid crisis forcefully, using all of the agency's tools and authorities. Finally, we've undertaken new efforts to support novel product innovation, and this includes innovation in treatments for opioid addiction. But somehow, it doesn't translate, right? Because we all know that this is a crisis, and all the federal agencies are very activated around this, but there's some disconnect between what's really happening on the ground and then trying to figure out solutions to get treatments to those who need them. So I would really like to see some of that improve. So the last primary approach has been to address the harms, the treatment of infectious disease, naloxone distribution, which has really taken off all over the country, and syringe service programs. So it's not only drug users that and drug treatment for substance use disorders that are stigmatized, and the providers and the medications, but when a substance user actually becomes sick with something else that's somehow related to their substance use disorder, they're also stigmatized for that. And so I'm going to talk about two different situations. I'm going to talk about infective endocarditis, and I'm going to talk about hepatitis C. So infective endocarditis is an infection in the heart valves or the endocardium. The standard of care may include surgery, depends on what valves are involved, and it may lead to a valve replacement, and a typical 6-week course of antibiotic therapy delivered through a PICC line, a peripherally inserted central line. What typically happens if someone gets endocarditis is they get medically stabilized in the hospital, and then they get discharged home to home health care with an infusion service that comes to their house, and they can then go ahead and get their 6 weeks or 4 weeks or whatever's left of their antibiotic therapy. So there's great risk to develop endocarditis if you're an injecting drug user and you're not using sterile syringes, which may or may not be available because some places they're actually illegal and they're paraphernalia. Other places have syringe programs, but not all. So persons who have intravenous drug use histories have been historically excluded from studies on IV antibiotics at home through PICC line, and this is outpatient therapy with antibiotics, is OPAD. And they've been excluded because there's a bunch of assumptions that don't have any evidence. So these assumptions include that if a patient is an IV drug user, clearly they will inject into their PICC line if the PICC line is there. If they're discharged with it. But that same patient won't inject into their PICC line if they're kept in the hospital somehow. I'm not really, the logic, I'm not sure about that logic. And that the hospital is safer. And we all know that the hospital is not safer, right, with all the potential infections that one can get. So what ends up happening with people who are IV drug users is that they're typically required to remain in the hospital for the full 6-week period of antibiotics. What also happens commonly is that individuals who have opioid use disorder are not actually able to receive evidence-based treatment for their opioid use disorder while they're in the hospital. So they go into withdrawal. and then they're being treated for the underlying condition, and maybe that includes a $400,000 surgery, but it doesn't include a daily dose of buprenorphine to suppress their withdrawal and help them to feel better. So what ends up happening is that there's a lot of bad behavior that takes place. And so then the nurses become angry and the physicians become angry, and they're looking for the patients when they're supposed to have a test and they're outside because, you know, they're trying to find something maybe that will suppress their withdrawal. So we think a lot of this is really driven by stigma. And so we wanted to try and evaluate whether or not there could be a different approach and whether or not we could test some of these assumptions that people have about what IV drug users would do if they had a PICC line. So we wanted to determine if inpatients with opioid use disorder and injection-related infections could be safely discharged with outpatient therapy for antibiotics in the context of a comprehensive outpatient opioid use disorder treatment with buprenorphine. And so we conducted this small pilot proof of concept randomized parallel group trial. So in the study, we randomized 10 participants to usual care, which meant that they had to stay in the hospital for IV antibiotics for the full duration. And the other group was discharged early. So as soon as the medical team decided that that group was ready for discharge because they were medically stable, then they came to us. So the other thing that was important is that both groups received buprenorphine in the hospital, which would be kind of the evidence-based care that you would want to deliver. So everybody was made comfortable while they were in the hospital, and the difference really was when they got to leave. And this graphic just shows the design. So basically, there's two groups as usual care. So they stay for their antibiotics, and then they would come for 12 weeks of outpatient care, and we would monitor them there. They would have been finished their antibiotics, but we would have continued their treatment for opioid use disorder. And then the other group would discharge early, and they would also, at discharge, start this 12 weeks of treatment, but they would complete their antibiotics on an outpatient basis. So these are some of the preliminary data that we have looking at the proportion of illicit opioid-negative urines. This is after discharge, and what we can see is that the group that discharged earlier actually did better than the usual care of people who stayed in the hospital for the duration. We also found that 100% of the patients in both groups completed their antibiotic regimen, so it wasn't an issue to have people go as outpatients and think that they're just not going to come back or they're not going to be adherent. That wasn't the case. And the length of stay, the mean days for the length of stay, was almost 46 days versus 22 days. So we reduced the length of stay in the hospital by 23 days, which if you were in hospital finance, you would think that that was actually kind of remarkable because all the time hospitals are trying to do something that will reduce the length of stay by like a half a day, right, so that they can open beds. And then finally, you can see how many days they had outpatient antibiotics, and there was one aberrant person in the usual care that ended up discharging AMA, and that's why you see some days there. But the average length of antibiotic treatment that patients were largely managing on their own was about 20 days. And the reason I said that they were managing them on their own with our help. And the reason for that is that home infusion programs will not go to the home of someone that they know is a drug abuser. And residential care treatment programs for substance use don't have skilled nursing, so they can't manage a PICC line. So it's like this double-edged sword. So instead, we just let them languish in the hospital, which they're not happy about, and neither is the hospital. So to summarize that small study, people were able to successfully complete 3 weeks of antibiotic therapy in patients with opioid use disorder and injection-related infections. We had similar treatment retention. We had no evidence of PICC line misuse. We actually asked questions about that and whether or not they had urges to do it. There was no evidence of that. And the outpatient model was a little bit more intensive than typical outpatient antibiotic therapy, but it was very feasible and it was highly acceptable to the patients because honestly, one of the experiences that we had was that the patients felt really empowered because they were given this responsibility. And we were able to also tie their visits with infectious disease to visits with the behavioral health team. And it was far less expensive than hospitalization. And so the final thing I'm going to review is just a little bit of work that we're doing in collaboration with NIDA around hepatitis C. So this is another area where we have stigma and assumptions that impact the delivery of care, that if someone were not a substance user, there would be a different standard for how they would be treated than if they are a substance user. So there's some assumptions that you hear pretty commonly from practitioners that individuals who use drugs should be excluded from treatment completely. So I'll tell you that we have probably anywhere between 60 to 70% of patients who are in methadone treatment programs or who have histories of injection drug-related behavior will be hepatitis C positive. So this is a very large population that needs treatment, so it's not really practicable or ethical to exclude them. People believe that even if they do qualify, they won't be adherent to the treatment regimen. And then, of course, there's all kinds of other structural barriers to care, including insurance. So back after the HIV outbreak in Indiana a few years back, the CDC undertook this study to identify areas that may be vulnerable because of infrastructure for an outbreak of HIV or HCV. And they identified 220 counties across the United States. Of those 220 counties, 54 were in Kentucky. So we were definitely overrepresented in this area. In response to that, our state legislature quickly changed the law to allow syringe services programs, as recognizing that that would be one of the first line things that you could do to prevent injection-related infections. And to date, we have over 50 programs operating throughout the state. At the same time, one of my colleagues, Jennifer Havens, has had this really remarkable longitudinal study underway that's been funded by NIDA for over a decade now to determine vulnerabilities to prescription opioid abuse and associated harms in rural Appalachia. So this takes place in eastern Kentucky, which is a very poor and very, very rural area, has poor internet coverage, low education, high unemployment. And the purpose originally was really to determine the prevalence and incidence of hepatitis C and HIV and other infections in relation to social network characteristics in this rural area. So looking at sex networks and drug-using networks and how that might facilitate or impede transmission of infectious disease. So she's been studying 500 rural out-of-treatment persons who use drugs that were recruited and have been followed now at 7 waves of data collection. And this slide just illustrates the proportion of participants who are injecting drugs. So at this is the actual proportion, the height of each bar. And then in red is the proportion of those who have tested hepatitis C positive. So in this cohort at the baseline, it was about 43% were hepatitis C positive. And in 2018, our prevalence was about 66%, with 73% of those RNA positive, meaning that they are treatment eligible. But not one of them was receiving any treatment for hepatitis C. And there are a number of reasons why. They had lack of access to evidence-based substance abuse treatments. They had very few hepatitis C treatment providers in the areas. Just as an example, in the whole eastern half of the state, there wasn't a single FibroScan that was available, and there are only a few gastroenterologists. And the ones that were there didn't want to treat people who used drugs. They had no access to harm reduction, and there were lots of risks that were related to these social networks. So what's the solution to this problem? And so in conversations with the interim director at the time, Doug Lowy, at the National Cancer Institute, and Dr. Volkov from NIDA, this project was discussed that could go in and actually serve as a demonstration project as a new model of care and how to use treatment as prevention of spread of an infectious disease. And so the objective was to develop a model to improve hepatitis C treatment access and delivery in rural areas that could be exported to other places, where we could have an affordable drug, we could incorporate evidence-based substance use disorder treatment where none's previously available. And in the model, we would be training mid-level providers on delivery of care because mid-level providers are far more available than primary care or specialist providers, and that we would use case management to remove barriers to care. So this is one of our newest studies that we are just launching, and we're so excited about it. It's called KeyTreat, and it's a unique initiative to increase access to care and demonstrate efficacy and effectiveness. And as I said, it's supported by both NCI and NIDA. And the CDC and NIDA actually supported the launch of a syringe services program in Perry County. So Perry County The seat of Perry County is Hazard, Kentucky. And it is as rural, as Appalachian, as poor as a place can be. Also very proud. But they were approached about this project, and it was, you're going to have a syringe services program. We don't want people getting reinfected. We wanted them to have resources. And the CDC was willing to support that. And so with that, the Public Health Department approved this, and we opened this SSP in Hazard, Kentucky, mid-year last year, which is really exciting. And Gilead Pharmaceuticals donated a boatload of Epclusa, which is very, very expensive. The amount that they donated is probably estimated around $60 million or so for this project. And so the goal is to engage every single person who's HCV positive and a Perry County resident in treatment to receive direct-acting antivirals and to compare them to a control county. And as I said, the treatment will be delivered by mid-level providers, which will enhance sustainability and demonstrate feasibility, and will increase access to all the necessary ancillary services. So it's a big implementation project that hopefully will be able to export this model. So with that, I'm going to close, and I'm going to just have a few concluding thoughts. And my first thought is that we should stop providing tax dollars to programs that do not allow medications for opioid use disorder. It's just as simple as that. I mean, we know what the evidence is, and being here at NIH, this is the place where we discover the evidence. Some of the other agencies don't know what the evidence is, so we need to educate them, and we need to stop spending money on things that don't work and actually things that may increase risk. We should lift the ban on federal dollars for safe injection equipment, because our problem actually isn't getting less, it's growing. We need to reduce the structural barriers to care. We need to fight efforts to reverse or pull back the ACA, because this has made a huge difference in expansion states by providing coverage for substance use treatment. And we need to stop insurance companies from setting limits. So we have insurance companies that will say that people have to fail first, which in the case of opioid use disorder, failure might actually mean death, and then they definitely wouldn't have to pay. And then we need to set reimbursement rates sufficiently to encourage and increase good practice providers. And then finally, I just think that all the agencies need to get together, and the scientific community, because we need to respond like it's an emergency, because it is. Thank you very much.
Sharon, thanks very much. I'm going to help guide the questions. There are 2 microphones. We'll go left and then right and then left. And so, David, you go first left.
Thank you, Nora.
Thank you.
The Continuum lecture that Robert Redfield gave earlier this year here was really the perfect complement to your talk. I think he was standing on the other side of a stage. But there were 2 white papers published in 2018 that were not so complementary to each other on the needle exchange and other harm reduction programs. As you well know, there was the RAND report early in 2018, and then in December, the Brookings Institute report, which, looking at community impacts of the programs, showed that yes, HIV infections were reduced, but that there might be other harmful consequences. So where do you think that the evidence stands on needle exchange and similar harm reduction approaches?
Can you describe to me what the other harmful consequences were?
Yes, so the other harmful consequences in the Doliak report from Brookings were that there were more emergency room admissions and there were more opioid-associated crimes. And so what they did was that they looked across crime databases and ER databases. There's also I think a young graduate student or postdoc who's at Miami University. Her name may be Pelham or Parham, who's done a nationwide analysis of these programs. And so, for sure we need more evidence, but, I was curious if in your studies that you also have an idea to look at community impacts beyond the beneficial impacts to individual addicts.
So Well, so let me just respond about what I think the evidence is, because I think that the evidence is really, really strong that syringe services programs reduce infectious disease, which you noted as well, and also provide a really critical linkage when used properly to get people into treatment, which is ultimately where we want them to go. I think there's so there have been, syringe services programs have been around for a long time, and there are a lot of really good empirical data to support the benefits of those. I think there's always a risk when you do these kind of big correlational studies and you're looking at if this goes up and that goes down, then somehow it's causative. And so depending on what your political leaning is, it might be easier for you to make that conclusion that something is actually causing something else. I mean, I can tell you that in new communities where we've rolled out syringe exchange, where there's been, syringes everywhere strewn about the street. As soon as the syringe program comes, that's when people start complaining that there are syringes strewn about the street, as though the syringe service program is actually the one that's doing that, even though they're taking them all back, in a safe manner. So I think that the evidence for public health benefit is undisputed. And honestly, I have a very hard time understanding how a syringe service program might increase crime.
Thank you.
You're welcome.
Yes, good afternoon. First, I just want to thank you for coming here and addressing a very important issue. I just wanted to take a moment and just give this message to my NIH colleagues. So in response to the U.S. Surgeon General's Advisory Council that training on naloxone and having it in hands reach can save lives, we've actually, the NIH Public Health Service Corps officers have launched a training program, and we want to welcome everyone to come, and it's a free training, and we're going to be rolling out, Lieutenant Blake is here, one of my colleagues, we're going to be rolling out multiple sessions for everyone to come and be trained, and we'll also let you know how to get your free naloxone to have in your pocket to save a life in the future.
Thank you very much for that, yeah. Thank you. I think the more available that we can make naloxone, and when we've got barriers there too, it's costly for one. I just did naloxone training again this last weekend, and it was like 3 minutes long. But I walked away with a naloxone kit, which not everybody's able to provide in a kind of widespread way. But if we could have naloxone available in vending machines, and we could have it not, under prescription and over the counter, I know that it would have an even bigger impact than it's having right now. So I'm really glad to hear about that program, and encourage everybody to take part, please.
For a complex issue, I guess, where you have maintenance, delivery, and all the other things, the long-term implant looks the most promising one, because it is already there and they are getting the medical benefits. I was thinking about your buprenorphine delivery for long term. So do we, just like vaccine, do we have some pool of money to develop a technology which could be provided once it is identified, and pursue it for use it at a higher level than what it is available now?
So is he asking about vaccines?
Do we have any vaccines for treatment of opioid use disorder?
Yeah, so there's a lot of interest in the development of vaccines for opioid use disorder, and NIDA is certainly supporting a lot of investigators to develop vaccines. Opioids are a little bit tricky. There was a cocaine vaccine, there's been a nicotine vaccine, and neither of those made it onto the marketplace. But the thing that they had over the opioids was that nicotine is a single molecule and cocaine is a single molecule. In the opioid area, we have a lot of different structures of opioids that are being misused. So if you want to develop a vaccine that's going to recognize a specific structure, then it needs to be a multivalent type of vaccine. And so one of my colleagues, for example, is developing a multivalent vaccine that would recognize oxycodone and its analogs, which are numerous, and then also heroin. But the FDA wants them to do a stepwise process where they developed one vaccine first, the second vaccine second, and then they can test the multivalent vaccine. So that tells me that's 15 years away by doing it in that kind of sequential approach. I'm not criticizing the FDA for that. I mean, I understand the concerns about safety, but it is very tricky because we're not just trying to target one thing.
Well, more power to you. Thank you.
Go ahead, please. You can comment if you want to. You know more.
Yeah,
about
no, Wilson.
Oh.
Thank you, Sharon. Wonderful lecture. As we're seeing some shifts in the epidemic to include stimulants, particularly methamphetamine in regions like Kentucky and Ohio, which you're quite familiar with, what are your thoughts about how we need to modify treatment? Because some of the opioid treatment programs are now thinking that they're not well equipped and they're not quite sure what to do when their patients are suddenly showing up with significant amounts of methamphetamine.
Yes, despite a few decades worth of effort in trying to identify medications for stimulant disorders, we still are lagging behind. We haven't been very successful. Methamphetamine is a whole different animal, to be honest with you, and it is on the rise. I mean, in our hospital alone, if we look at infective endocarditis cases, probably about 50% of those are primary methamphetamine injectors rather than opioids, and may or may not have opioids involved, but it's not their primary issue. And so in the absence of having effective pharmacotherapies, I think that we really need to understand a little bit more about what types of structured behavioral interventions are effective for that population, and maybe even revisit some things like contingency management in social programs that we haven't really been focused on too much for a while. But it's very difficult because when we see people come in with methamphetamine use disorder, they're very, very sick. And it's a very, very destructive drug. I mean, we think of opioids as being very destructive because you can make one mistake and die. But methamphetamine exposure on a chronic basis is really, really harmful. What do you think from the NIDA perspective?
Well, we certainly, I raised the question because we're hearing more about this, and I certainly agree with you that considering the addition of some of the behavioral approaches that have proven efficacy at least gives some hope to the treatment program to give them something that they can add to their armamentarium. I also think it's important that that not be an excuse for stopping the effective treatment for the opioid use disorder.
Oh, I agree. Yeah, I agree completely. I mean, I think, and I don't know if you would agree with me, that probably the strongest evidence for a pharmacotherapy for methamphetamine is probably methylphenidate or one of the other stimulants that were explored a number of years ago. But for those, you know, there's a relatively small signal, and I think that there's also some risk that comes along with being sustained on a stimulant. So
I'm not quite willing to recommend that as a routine.
No,
treatment.
I'm not recommending it. Although I know providers that will actually prescribe it, and I usually say, yeah, I don't think that that's a good idea. I'm just thinking out loud though about kind of we've explored a lot of pharmacotherapies for stimulants, and we've really gotten very little signal, right, in the stimulant area. That's probably the biggest signal, but I don't think it would warrant approval by any stretch.
And in fact, one of the things that we are prioritizing for immunotherapies is methamphetamine. And we have actually monoclonal antibodies against methamphetamine that are quite effective. So the issue is the challenge being how do you create an antibody that can be used for treatment, because you cannot justify giving it on a weekly basis since it's very expensive and the compliance is very low. So we're working on trying to develop long-lasting monoclonal antibodies for methamphetamine. And this is much more likely to be successful than vaccines, because the problem with vaccines is that you cannot rise the titers sufficiently high. But if you are giving the monoclonal antibodies, you would. And here you have one drug. I mean, of course, what we're observing, as you know, and you said, people are combining drugs, but certainly if we can interfere with methamphetamine getting into the brain, we can actually extinguish the associations that the user has with the drug.
Right, right.
So that is the process. So that is one of the things from the perspective of therapies, pharmacotherapies, that looks more promising. I mean, as you mentioned, the area on the stimulant medications, we've spent millions of dollars on stimulant medications to treat cocaine and methamphetamine, and the signal is very weak. And so that it's not going to be the panacea. And I think that the other aspect, though, that I think we have to think more and more in addiction, not just for methamphetamine, but for other addictions like opioids, is we've been actually, I think, a little bit of a magical thinker and expecting that a drug is going to do a miracle. And I think that we have to recognize that the medications may improve certain parameters of the addiction process that by themselves may not be sufficient. So use what the HIV people have been doing, combine treatments.
Right, exactly. Yeah.
And that we've been under investigated. So I am actually excited about it. I'm also excited about the notion of neuromodulation technologies for the treatment of stimulant addictions like methamphetamine.
Yeah, so I'm going to piggyback onto what Nora said. There's a couple of other comments that I would like to make. One is that substance use disorder is not just pharmacology, okay? It's much more complicated than that. And so people don't become an intravenous drug user with all the other things that kind of come with that lifestyle as an empty slate, okay? So lots of times there's trauma, psychiatric disorders that are antecedents or that develop as a function of this. There's all kinds of other things that lead to this. So if you think that the drug is the only problem, you're kind of missing the boat. So if you can get someone to the point, what we like to talk about is getting somebody into remission. And we don't usually use that term too much in the substance use field, but the idea that you can get somebody to stop the immediate symptom, which is using the drug, and then that provides an opportunity to work on all the other things to get them through recovery. And recovery is really about kind of getting your life back. And so when you're talking about the monoclonal antibody, it's not the case that somebody necessarily needs to be on treatment in perpetuity for the rest of their life. So if you can use something even in a short term, and we know, and we can do these, other wraparound services and things like that to help people get their life back in order, then we may be able to see people, not needing treatment anymore because they're in sustained remission.
George.
Yeah, your talk and the ensuing discussion very nicely illustrated that the ideal goal would be to treat the underlying addiction or at least manage it on a chronic fashion. Other approaches may be less effective in treating the addiction but could save lives, such as naloxone. Right. Your data showed naloxone is not very effective in inducing long-term remission, but it's in an acute situation can save lives. An alternative that could save lives would be biased agonists that would produce much less respiratory depression, which is usually the cause of death, than pain relief. So could you update us on what's the status of those compounds and whether they have any promise?
That's a really interesting question. I had actually hoped to get an update from somebody here today who is an expert pharmacologist around this topic. So the biased agonists seem to have a lot of promise, right? That we can actually separate out cell signaling pathways and we can turn one on and leave the other one off. I mean, this is still the holy grail, right? Where you can have a drug that's an effective analgesic but not have all the adverse effects. So that work has been going on for at least 4 or 5 years.
Probably longer.
Yeah, probably longer, but some of it getting into the clinic, for clinical trials. And what I saw most recently actually was not very compelling. And I don't know whether or not it was representative, but it wasn't achieving kind of what I had anticipated the promise would be. I was at a meeting this past weekend with a very well-known medicinal chemist, and he was questioning whether or not the biased agonists were really biased or not. And I thought, well, it's great to talk to a chemist, but I think I really need to hear from a basic pharmacologist that's doing work in this area and see where things stand in the field, because I think that they have great promise, but I haven't seen the supporting clinical results yet. Maybe Nora knows more.
Yeah, no, we're funding a lot of research, and actually, what happens when you speak about bias agonism is not like there is bias agonist or not bias agonist. A molecule can have more or less bias agonism, and what it means is just the extent to which you are favoring one intracellular pathway versus the other. And it's that intracellular pathway of the beta-arrestin that is supposedly associated with the respiratory depressing effects. So some of the drugs, and there's one that's undergoing phase 3 clinical trials for pain, that actually has a bias agonism of 2-to-1. In our intramural program, Amy Newman, for example, now has bias agonists that's 30-to-1.
Oh.
And that completely is a game changer. So researchers are working on developing drugs that are going to have a completely different set of intracellular signaling cascades, where it is very, very plausible that we could end up with molecules that would have, on the one hand, analgesic effects and minimal respiratory depressant effects. But importantly, and I think I'm George, I'm glad you're bringing it up, because for the most time, we've been focusing on that type of bias agonist for pain management, but it is as important for the management of opioid use disorder. So this is a dialogue that we've started to have with the researchers, and I think it's another area that looks promising as a treatment for opioid addiction and for pain. But if I can ask you a question, I think that, I totally agree with your concluding thoughts, and I'm certainly one would want to ask the question, why are we reimbursing for treatments for which the evidence shows that the relapse rate is basically almost 100% certain on a disease that has such a high mortality rate? I think that we're just inspiring a series of people that just want to open up treatment programs and says, trust me and come to me and charge you an enormous amount. So I think that an aspect that I find extraordinarily important for us to do is to build up a culture of evidence-based treatment of quality. So it's not just that you're providing evidence-based treatments, but they are quality care.
Yes. Yeah.
And make clinicians aware of that. But my question to you has in the concept, because obviously, as you may imagine, it activates my amygdala in the wrong way. When you are presenting the data where another extended release of formulation of buprenorphine that gives us much more flexibility and clinicians, and we were all waiting, and I have Betty Tai and multiple other researchers waiting to get their hands on these molecules, and we're not getting them approved. And since you were involved with the development and the research clinical trials that led to the outcomes that were positive, what is the thinking about why is this not going through? What are your thoughts? Because we were perplexed, we were disappointed. It's an emergency.
Yeah, so I'm completely befuddled, honestly. This is a tool, without respect to what company developed it, that's sorely needed right now. It could change the landscape of care, in rural areas that are harder to reach, where transportation to come to appointments is problematic. It was safe. It met the criteria. It was safe and it was effective. They came in at a later date than the first product, and then the decision was just made that they wanted to grant exclusivity to this other company. And I'm not a lawyer, so I don't really fully understand the rationale for that. But when I think about why you would want exclusivity, it would be because your product is actually the same, right? You're going to be in direct competition, and then there's not enough incentive for companies to want to be the first into the marketplace. These are not the same. They're not the same. One has a weekly and a monthly formulation. It comes across the full set of doses. And so when it was very shocking, honestly, in the context of this crisis, and with all the discussion amongst the federal agencies about how we're going to do everything that we can to respond to this crisis like it's an emergency, which is why that was my closing statement, it's a little incomprehensible to me that you could make a decision like this when it's really, really hard to see on the surface from an evidence-based framework that these are actually equivalent. I don't think that they're equivalent. I think that they're complementary. And so, we're trying to do what we know we can do. We're trying to get people that are leaders in the field to write to the FDA and let them know that they're concerned about this. I know that NIDA had a number of studies planned to deploy this. And I'll just say here, just to frame this better, when we started the pivotal studies here, this product hadn't been introduced anywhere else in the world. It is now marketed in Europe and in Australia. We started, and we still don't have it, and we're not going to have it for a few more years. And other countries who don't have the same problem, the same magnitude of problem that we have here, were able to just get it onto the marketplace. And that's, it's really disappointing and I think a very harmful decision. And I'm not sure whether or not the FDA will turn around on that, or whether or not it's just hung up with the lawyers. But in the context of this crisis, it would be really great if common sense could prevail.
And I think that the other thing, too, we are a science organization, and we're rational creatures. And just today we had a lecture on the Enlightenment, which we use Enlightenment to actually solve problems. And it just strikes me that, we should use the science and the data to actually document why this product could be valuable. And I think that that's ultimately why we're getting taxpayer dollar so that we can bring this information forward. So I would hope that there are means, and in terms of are there certain studies that could be done or certain added evidence that could help move it forward, because I do think it is an emergency and we don't have much time in our hands. But I do want to thank you for all the help that you've given to the field.
Thank you, Nora, very
Thanks
much.
very much.
I appreciate it, and thank you for your attendance.